Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Standard Medical Notes. So today we will discuss the topic of deep venous thrombosis. So actually it is a topic of many books. It is given like venous thromboembolism, which is a combination of deep venous thrombosis and pulmonary embolism. But we will discuss, because we are discussing about the cardinal manifestation of vascular diseases, we'll discuss deep venous thrombosis in particular here. So let's begin with the name of Almighty. So first of all, definition and epidemiology. DVT is the formation of a thrombus within the deep venous system, usually below the deep fascia. It most commonly affects the lower extremities, but can also occur in the pelvis or upper extremities. Clinical entity, so DVT, deep venous thrombosis, and pulmonary embolism are manifestations of the same disease process. What is that? That is venous thromboembolism. What's the incident? 1 to 2% of hospitalized patients have DVT. 1 to 2% of hospitalized patients have DVT. Remember, very important. Okay. And frequently these DVTs are clinically silent. And only 50% of cases detected by screening show clinically overt signs. That means patients have DVT, but only 50% of the DVT will manifest with clinical signs. That is very important point. That means deep venous thrombosis is very common in hospitalized patients, and they are clinically 50% of DVT are clinically silent. So we should have a high grade of suspicion patients with who are hospitalized. What is the burden? Untreated deep venous thrombosis carries a high risk of fatal pulmonary embolism, up to nearly 40% risk of pulmonary embolism, fatal that too. And if not in acute, not any acute event, then in long term, morbidity includes post thrombotic syndrome. What is that post thrombotic syndrome? Which is characterized by chronic pain, swelling, venous insufficiency in the affected limb, and patients will have venous ulcer. So eczema they will develop, and the limb will become like this. So this is known as inverted champagne bottle appearance. Inverted champagne bottle appearance. So in the long term, they will have post thrombotic syndrome, nothing but pain, swelling, and venous insufficiency. They can develop ulcer here, and they will have venous stasis eczema also. That is nothing but post thrombotic syndrome. Okay. So this is also seen in patients with varicose veins, superficial vein thrombosis. So remember one basic thing, that limb has the venous system of the limbs can be divided into two. So one is above the deep fascia, that is superficial veins, superficial venous system. Okay. And one is below the deep fascia, that is deep venous system. Okay. So there is a connection between, so if this is a superficial vein, and if this is a deep venous system, there is connection between the superficial and the deep venous system by something called as perforators. So you should understand this one first, basic thing. So what we are discussing is thrombosis here at this site. We are discussing thrombosis in this system. Okay, that is known as deep venous thrombosis. So improper functioning of this superficial veins or thrombosis, or improper functioning of these perforators, that will cause varicose veins, varicosity. Okay, just remember this thing. And sometimes because of blockage of the superficial veins due to some thrombus or inflammation, that is known as superficial thrombophlebitis. So this is the basic thing we should remember. Okay. So deep venous thrombosis is dangerous. Why? So we know that from this is the inferior vena cava, which will divide into the left and right, sorry, which will divide into the right and left. So this is the inferior vena cava, which will divide into uh, superior and inferior right and left iliac veins. Okay, I will just a schematic diagram, not proper. Okay, so this is the inferior vena cava, which will divide into right and left superior and inferior iliac veins. Then that will continue as femoral veins. Okay, then that will continue here as popliteal vein. This is at where popliteal veins, this is knee actually. Okay, this is knee. From the knee they will continue as superior and inferior deep super what do you call, superficial and deep tibial veins, tibial tibial veins. Okay, then comes the foot. Okay, so this is the thigh, this is the thigh, this is the pelvic region, and this is the leg. So this is pelvis. Okay, this is thigh, this is knee, and this is calf. Okay, now this is iliac veins. Okay, and this one is femoral veins, and this one is popliteal vein, popliteal. Okay, and this is tibial. This is important. So iliac, femoral, popliteal, tibial, this is important to know. Why? Because thrombosis can occur. So there is something known as proximal DVT, deep venous thrombosis, and distal deep venous thrombosis. Proximal deep venous thrombosis includes thrombosis above the tibial veins, meaning from popliteal vein, from here, from this point to this point. So this is known as, this is considered as proximal deep venous thrombosis. And this point, from this point to this point, this is considered as distal or calf vein thrombosis. This is important to know. Why? Because this requires management and this resolves spontaneously most of the time, but this distal vein thrombosis has the probability to spread to the superior vena cava, whereas proximal DVT does not have any probability to spread to the upside, meaning inferior vena cava, but this has more probability of causing pulmonary embolism. This has less probability of causing pulmonary embolism. Okay, so this is the whole workup. This is the whole workup. Okay, so this is the pelvis, iliac veins. Okay, femoral vein, popliteal vein, tibial vein. So from here, as I've discussed, this point to this point, from here to here it is proximal DVT, and from here to here it is distal DVT, meaning calf DVT. So this has a probability to spread to inferior vena cava, but less probability of causing pulmonary embolism. This may resolve spontaneously. This requires monitoring, and if it progresses to towards upwards, then it requires treatment. Whereas proximal deep venous thrombosis requires treatment. Because it has high probability of causing pulmonary embolism. Okay, so any thrombosis in the popliteal, femoral, or iliac vein requires treatment. Okay, any thrombosis in distal vein, meaning calf vein, we will monitor it first. If it progresses, then we will treat. So that is important thing, and symptoms also differ. Okay, so how do you know this? By doing ultrasonography or by magnetic resonance venography. By all these things, you will know this, the region where it is blocked. This is very, very important now, because management differs depending upon this. Okay, so that's about the whole anatomy, schematic anatomy of deep venous thrombosis. So in hospitalized patient, the probability is very much 50% are clinically silent. We should have a high suspicion. So in acute thing, it will cause pulmonary embolism. In chronic thing, this will cause post thrombotic syndrome. I explained now. Now key epidemiological notes: annual incidence of DVT plus pulmonary embolism, nothing but venous thromboembolism (VT) is 1 to 2 per 1000 population in Western countries, which is high actually. It is 0.1% to 0.2%. That means, okay. Risk increases with age. Remember, immobility, surgery, trauma, cancer, malignancy, and inherited thrombophilias. DVT is a major cause of preventable hospital mortality worldwide. Okay, so that's a brief on epidemiology of this DVT. So I said no, we divide it into distal venous thrombosis and proximal venous thrombosis. This is the types of DVT. So distal venous thrombosis are curved DVT. This involves the deep veins below the popliteal vein. Example, the tibial. Just remember tibial, posterior tibial or peroneal, which is a branch of tibial vein again. So often this is asymptomatic and it carries a low risk of pulmonary embolism, but it has high chances of propagating proximally. That we should see. Okay. Proximal DVT involves popliteal, femoral, and iliac veins. High risk of embolization to the lungs and high risk of post-thrombotic complications. That's why this needs treatment early. Iliofemoral is nothing but distal plus proximal combined. This is combined distal and proximal is nothing but iliofemoral. Okay. So iliofemoral is extensive thrombosis involving the iliac and femoral veins associated with severe symptoms. Not DVT plus distal and proximal. It is iliofemoral DVT, meaning it is a combination of thrombosis of iliac vein plus femoral veins, which is associated with severe symptoms, limb swelling, and higher risk of pulmonary embolism and post-thrombotic syndrome. So iliofemoral. So distal, proximal, and iliofemoral DVT. Remember this point. Iliofemoral DVT has the highest risk of pulmonary embolism and higher chances of post-thrombotic syndrome. So what is the pathophysiology? The main important thing you should remember is venous thrombus develop an environment of stasis and low oxygen tension. So these two conditions, this is the core principle. Stasis and low oxygen availability favors the formation of thrombus. Okay. So we have learned in already in pathology. So when does a clot form? It depends upon the Virchows triad. So wherever there is stasis, wherever there is endothelial injury, wherever there is hypercoagulability, these three things constitute the Virchows triad. There is the formation of clot. Example for that, state is impaired blood flow. For example, a bed rest patient, congestive heart failure. Long haul travel is nothing but a long travel, traveling through flight, which has a duration of 6 to 7 hours. So that is known as long haul travel. Okay. So that causes impaired blood flow and formation of clot. Endothelial injury, for example, due to vessel wall damage, seen in surgery, trauma, indwelling catheters. This is important. Okay. And hypercoagulability, this is because of prothrombotic state. Okay. Seen in genetic thrombophilias like factor V Leiden and deficiencies of the naturally occurring anticoagulants in the body, like antithrombin 3, protein C, protein S. So these are known as genetic thrombophilias. Malignancy is also a prothrombotic state. Pregnancy, oral contraceptives, hormonal therapy, and systemic inflammation. So this we have known till now, that Virchows triad, if you know, you will know the causes easily. So anything which causes stasis, endothelial injury, or hypercoagulability will cause thrombosis. But nowadays there is a modern concept of inflammation. So inflammation is also an important plays an important part for the formation of thrombus. So this is a modern expansion. How we got how we have when we have realized this, we have realized this during the COVID-19 pandemic, when there was cytokine storm in the patient's body. Okay, there was associated thrombosis in the patient, disseminated intravascular coagulation. So inflammation is also considered as a prothrombotic state. Okay, so inflammation is now recognized as a central trigger. How? Pro-inflammatory mediators activate neutrophils, and neutrophils release something known as neutrophil extracellular traps. What are these nets? So if this is a neutrophil and this is the nucleus of neutrophil, here will be the DNA of the neutrophil. So what this neutrophil will do in order to trap the foreign body or bacteria, what it will do in defense, what it will do, it will rupture itself to release its DNA. So this DNA will act as a trap, and it will trap the foreign body or the bacteria or the invading thing. So nets are nothing but the DNAs of neutrophils. Okay, but these nets are a problem. So these nets play a role in the formation of clot. So that's why inflammation plays an important role in formation of clot. So nets form web-like scaffolds that enhance platelet aggregation, thrombin generation, amplifying clot formation. So they will act as scaffold. So upon this scaffold, platelet will aggregate and thrombin will get activated, so thus favoring the formation of clot. So this is a modern concept, that inflammation causes thrombus formation. Next thing is interaction with atherothrombosis. I will decrease the size. Okay. So VT shares mechanistic overlap with arterial conditions like myocardial infarction and stroke. Patients with venous thromboembolism have a 2 times higher risk of future arterial events. This is important. So patients with venous thromboembolism have a 2 times higher risk of future arterial events. This suggests a systemic prothrombotic and inflammatory connection, meaning linking inflammatory milieu linking venous and arterial disease. That means if a patient had some arterial event, then you should also bear in mind that the patient will have a high probability of having a venous event also, like deep venous thrombosis or pulmonary embolism. So arterial events are linked to venous events. That is the main goal of. So if a patient is susceptible to venous events, then he has 2 times higher chance of susceptibility to coronary events. Sorry, vascular events. So if patient has vascular events, then he will have higher chances having venous events. So that is a link between vascular and meaning arterial and vascular venous events. So that is one thing we should remember. So but there is a difference. Okay, thrombus composition is different. Okay, venous clots have fibrin rich with trapped RBCs more in venous clots. Unlike in arterial clots, you will have platelet rich arterial clots. So in venous thrombi you will have RBCs more, whereas in artery you will have platelets more. Okay. Hypoxia, low oxygen tension upregulates why hypoxia causes this thrombus formation? Because this will upregulate a factor, prothrombotic factor known as hypoxia inducible factors, promoting procoagulant gene expression. That's why hypoxia, for example, in patients COPD, heart failure. So these are patients who are they are hypoxic actually. So they have a high risk of venous thromboembolism because of these upregulation of hypoxia inducible factors. Now endothelial dysfunction. So reduced nitric oxide production and prostacyclin production further tilt the balance toward thrombosis. So endothelial dysfunction you will see in patients with surgery, trauma, and in patients with, who are smokers. So this smoke will cause continuous endothelial injury. Okay. So what is the clinical relevance in between these hypoxia, endothelial dysfunction? Okay. Understanding the inflammatory and systemic links help explain why anticoagulation alone may not fully mitigate long-term vascular risk. That means if you give just anticoagulants, that may not be that only may not be sufficient, because you are not seeing the inflammatory factor there. So you need to treat this inflammatory factor also, because inflammation plays a vital role in the formation of thrombus. So this low grade inflammation is found in many patients, like in patients with asthma, in patients with COPD, in patients with diabetes mellitus, in patients with hypertension. There is low grade vascular inflammation. So you should address that inflammation also in addition to this anticoagulant. Just giving anticoagulation is not enough. That is the inference which we draw from this. So just remember Virchow's triad along with inflammation. So inflammation has an important role in the formation of thrombus along with Virchow's triad. Okay, and hypoxia also. Okay. So some inflammation linked conditions that can trigger pulmonary embolism and deep venous thrombosis. For example, ulcerative colitis, Crohn's disease, rheumatoid arthritis, psoriasis. So these are all autoimmune disorders. Remember, autoimmune disorders. I will change this to blue. Okay, these are all autoimmune disorders. Type 2 diabetes mellitus, obesity and metabolic syndrome, hypercholesterolemia, elevated LDL cholesterol, pneumonia, infection, coronary syndrome, vascular arterial event. Okay, acute stroke, cigarette smoking, sepsis, ESAs, erythropoiesis stimulating agents, blood transfusion, cancer patients. So these are all the conditions where you see what you see inflammation. So that means in these conditions there is a high chance of thrombus formation. So these are autoimmune disorders. So this is IBD, inflammatory bowel disease, rheumatoid arthritis, and psoriasis. So this is diabetes mellitus. This is metabolic syndrome, dyslipidemia. Okay, and these are vascular events: coronary syndrome, acute stroke, and this is infection, sepsis, pneumonia, sepsis and septic shock. And this is a modifiable risk factor: cigarette smoking. Okay, and erythropoiesis tumoratic angina, which is given in patients receiving chemotherapy or patients with CKD. Okay, blood transfusion, cancer patients, because cancer itself is a prothrombotic state and also an inflammatory state. Okay, so these are all inflammatory states, but that can trigger pulmonary embolism, and deep venous thrombosis. Okay, so these are some inflammatory conditions linked to the formation of thrombus. So this is a diagram which is given in Davidson to show the formation of uh, to show the events like which occurred in patients like venous thromboembolism, myocardial infarction, disseminated intravascular coagulation because of this COVID-19. So the patient had risk factors like acute illness, bedridden, stasis, genetics, fever, diarrhea, sepsis. Again, see, in fever or diarrhea, why these are prothrombotic? Because this causes dehydration. So dehydration will increase the what do you call, viscosity of the blood. Dehydration increases the viscosity of the blood. That's why it is a risk factor. Liver injury. So the why liver injury causes increased risk? Because this the naturally occurring anticoagulants are not synthesized. CKD, here the naturally anticoagulants like antithrombin 3, protein C are lost through kidney. COPD, hypoxic, so increased thrombin. High heart failure, again same. Maglin, same. So what this will do? This will cause an inflammatory response that will cause endothelial dysfunction with super infection. So what will happen? There is decreased regulation of tissue factor, plasminogen inhibitor. So this is an anticoagulation anticoagulant actually, which is in the body. Tissue factor plasminogen inhibitor. So that is down regulated. Lymphopenia is there, and there is a cytokine storm where there is increased interleukin 6 and CRP. So what this will do? This will cause pulmonary microthrombi, intravascular coagulopathy, myocardial injury, increased cardiac biomarkers, increased D dimers, decreased platelets. So the result will be increased risk of venous thromboembolism, increased risk of myocardial infarction, increased risk of disseminated intravascular coagulation. Disseminated meaning spread, intravascular meaning in the vessels, coagulation meaning thrombosis. So there is widespread thrombosis in the vascular system of the body. That is disseminated intravascular. On the other side, because the platelets and coagulation factors are consumed, on the other side there will be increased bleeding tendency also in the patients with DIC. Okay, so the conclusion here is in pathogenesis. So the main thing is Virchow's triad. Along with that, we should consider inflammation as a factor for thrombosis. So stasis, hypercoagulability, endothelial injury plus inflammation, these four constitute, and hypoxia, number one, 5 factors, hypoxia. So these 5 factors are responsible for prothrombotic state in the body. So what are the clinical risk factors? So that was about pathophysiology. Okay, so clinical risk factors you can divide into genetic primary risk factors, nothing but inherited factors, acquired factors, and indwelling catheters. This is how in the book it is given. Okay, so acquired factors include important things: active cancer, obesity itself is a prothrombotic state because it is associated with inflammation. Okay, and dyslipidemia. Okay, cigarette smoking causes endothelial injury, systemic hypertension causes endothelial injury, pregnancy, prothrombotic state, estrogen containing contraceptives, again prothrombotic state. Remember to here is cancer is one of the strongest acquired risks, especially with chemotherapy or immobility. Obesity contributes via venous stasis and chronic inflammation. Smoking promotes endothelial dysfunction and hypercoagulability. Pregnancy and estrogen therapy increase risk through hormonal prothrombotic effects. So just how to remember? So it is very striking deep. You remember like you divide the factors into acquired factors. Okay, acquired factors, genetic factors, indwelling catheters. In acquired factors, cancer, obesity, cigarette smoking, systemic hypertension, pregnancy, and estrogen containing contraceptives. In genetic factors, mutation in factor 5, that is known as factor 5 Leiden. Other thing is prothrombin G20T G2021-0A mutation, and deficiency of anticoagulants like antithrombin 3, protein C, and protein S. So these are genetic factors. Indwelling catheters, centrally placed venous catheters, and peripherally intravascular lines. So centrally placed intravascular catheters are important cause of upper extremity deep venous thrombosis. So the risk is amplified by catheter size, duration, and associated infection or malignancy. In genetic factor 5 Leiden is the most common inherited thrombophilia in white population. Causation is in white population. Prothrombin mutation increases the risk of recurrent venous thromboembolism. This is very important point. So factor 5 leader is the most common cause. So how you will suspect a patient? Maybe he is having a genetic thrombophilia. So they will have recurrent thromboembolism. That's how you suspect them. Naturally occurring anticoagulant deficiencies like antithrombin 3, protein C and S are rare, but they confer a very high risk, often presenting at a young age. This is the second important point to suspect genetic possibility. One is young age and second one is recurrent venous thromboembolism. So these two things will help us. So any patient, young patient or recurrent venous thrombosis patient who is coming to us with venous events or arterial events, we should suspect in them maybe that patient having genetic thrombophilia, meaning genetic inherited prothrombotic states. These are acquired and indwelling catheters. Catheters are responsible for mainly, you remember, upper extremity deep venous thrombosis. Okay. Some additional upgrade upon this. Just you remember these three. This is additional upgrade. So age also increases the risk of thrombosis increases with age. Hospitalization immobility increases because of stasis. Surgery trauma, endothelial injury immobility. Chronic diseases, hypoxia will be there. CHF, COPD, nephrotic syndrome. Okay. Combination effect, multiple risk factors often act synergistically, dramatically increasing the VTE risk. Okay, age, hospitalization, immobility, surgery, trauma, chronic diseases, all these things you should remember. So these are all risk factors. So remember, in deep venous thrombosis, we don't focus on investigations more. Even if the investigations are not available now, sometimes what happens is investigations you can't able to do. For example, D dimer you will not be able to do. Some rural areas you will not have this ultrasound, or ultrasound may be not showing any clot, but MR venography may be showing some clot. So sometimes the decision to treat is taken based only upon the risk factors only. So venous thrombosis is the treatment and management of venous thrombosis is mainly dependent upon the risk factors and the symptoms. Remember, investigations have a just confirmatory role, but the treatment and management are very much highly dependent upon risk factors plus clinical symptoms and signs. So that is the takeaway point, okay, in this. So what is the clinical presentation? So you can divide the clinical presentation so like this: symptoms, key signs, and some special clinical forms. Like this you divide and discuss one by one. See, I will not go into deep. First we will take it superficially. So symptoms include cough pain, persistent Charlie horse cramping. So nothing but muscle cramp. That is persistent cramping. Just remember, persistent cramping. Cough pain, cramps, swelling, redness. These are the symptoms. What are the signs? Unilateral swelling. How you will know? Compare. So more than or equal to 3 centimeter difference in calf circumference, which is measured 10 centimeter below the tibial tuberosity. So unilateral swelling. Okay. Pitting edema, usually confined to the affected limb. Homan sign. So this is calf pain on passive dorsiflexion. This is present only in 50% of patients. So this is not non-specific sign. So don't rely on this sign and don't take decision on this sign. Palpable cord suggests thrombosed superficial vein. Upper extremity DVT. So there will be asymmetry in supraclavicular fossa or upper arm circumference. Okay, that's how you suspect upper extremity DVT, supraclavicular fossa and upper arm circumference. Okay, so that's about the symptoms and signs. Signs you just remember: swelling unilateral, how much? Okay, this much. Edema, okay. Palpable cord, okay. And this is about upper extremity. In this you should remember, now you will go in deep. Symptoms are often non-specific and may mimic a muscle strain only, muscle cramp, just muscle pain. The patient may have symptom, and pain is typically worse with standing or walking. Pain is typically, and this is a persistent pain. Okay, so any patient coming as muscle pain also, he may not be having any swelling. Okay, muscle pain with risk factors. Okay, well score more than 4. Okay, well score more than 4. Well score, if he is having high probability, means well score is showing medium to high probability, and he just having cramps, you should proceed for D dimer or ultrasonography. In signs, remember, unilateral swelling is the most reliable sign. Homan sign is not, it is historically taught, but it lacks sensitivity and specificity. Upper extremity DVT is often catheter related. Remember, catheter related. That's about the clinical symptoms and signs. So a superficial, this is one point. Superficial palpable cord also, if you find a thrombosed superficial vein, then also you should suspect deep venous thrombosis. So some special clinical forms. So these are extreme forms of deep venous thrombosis. One is phlegmasia alba dolens. Second one is phlegmasia cerulea dolens. Alba means white, cerulea means blue. So the limb will be milky leg. Severe edema will cause arteriolar spasm that will cause pale limb, milky white limb. Alba dolens usually you see in pregnancy and postpartum states. Remember, alba dolens where you see in pregnancy and postpartum states. Bluish limb threatening emergency. So cellular dolens is a limb threatening emergency. Limb threatening emergency with near total venous occlusion. Severe cyanosis will be there, ischemia and risk of gangrene will be there. So cellular dolens requires urgent intervention, anticoagulation, thrombolysis or thrombectomy. Mortality is high and amputation risk is also high. So some upgraded clinical points. So silent DVT in up to 50% of cases may be you may be seen, and that is detected only by imaging. Differential diagnosis you should know. So cellulitis you should keep in mind. Baker cyst, rupture, lymphedema. These are three important differential diagnoses for deep venous thrombosis. Cough, bedside pearl. A combination of risk factors plus unilateral swelling is more predictive than isolated signs. Okay. Severity spectrum ranges from asymptomatic cough DVT to limb-threatening phlegmasia cerulea dolens, which is an emergency. Okay, this is the severity of deep venous thrombosis. Okay. Okay, we have discussed about the clinical presentation, physical examination. So just to summarize the clinical presentation. So deep venous thrombosis is a spectrum. Okay, it is a spectrum. So here you will have patient who are asymptomatic. Okay, asymptomatic to here phlegmasia like patient, phlegmasia cerulea dolens. Okay, asymptomatic to phlegmasia. This is the spectrum of DVT. So anywhere here you can have some just pain, then you will have again here you will have some swelling. Okay, and here you will have maybe this emergency. Okay, or if patient may have pulmonary embolism after that, or if not pulmonary, patient may develop post thrombotic syndrome. So this is the spectrum of DVT, you should remember. Okay, important to remember. Takeaway point here is you should always remember clinical risk factors are very important. So to remember risk factors easily, so you can classify them as inherited risk factors, acquired risk factors. Inherited, when you should suspect, I have already said, and catheters have an important role. And if you want to remember the causes, you remember the Virchows triad and inflammatory conditions, and you remember the classification of DVT, very important, that proximal DVT from distal DVT and iliofemoral DVT. Okay, iliofemoral DVT is the most high mortality because high chances of pulmonary embolism is there in that. So proximal DVT constitutes iliac, femoral and popliteal veins, whereas distal only cough. Management of these two is totally different. And in clinical part, most of them, 50% of them are asymptomatic. Some can present only with pain. Okay, some can present only with swelling. Okay, some signs you will have. Hormone signs is not reliable. So decision is taken mainly on the risk factors, not based. Even if the patient has clear investigations like radiological investigations and all, even though and if symptoms and signs with risk factors are present, then also we will treat the patient. So that is the main thing we should remember in our mind. Okay, there are some emergencies like this cellular dolens is an emergency. Okay, the patient can develop any time gangrene. So here the image shows, see, so this is the emergency. So what happens here, already discussed. No, because of lot of thrombosis in the veins, there is ischemia to the limb. So this is the early phase of phlegmasia cerulea dolens. In the late phase, B to D, there is development, there is necrosis and development of gangrene. See, so this is phlegmasia cerulea dolens. It is an emergency. Okay, and this is alba dolens. See this limb. This is milky white in color, not clearly shown in this image. So alba dolens, which is seen mainly in pregnant women and perpural period. Okay, and this is a simple case of this one. This one is a simple case of deep venous thrombosis. You can see this right leg is swollen compared to the left leg. Okay, just there is a swelling. Okay, So now it can be a big ruptures Baker cyst, or it can be filariasis, meaning lymphedema, or it can be deep venous thrombosis, or one more differential diagnosis. It can be cellulitis also, but no cellulitis, no redness or something like that, or fever, nothing is there. So confirmation is by D dimer and imaging modalities. So next is diagnostic workup. I think we will discuss that in next video. Thank you.